Hello everyone, thank you for joining this session today. My name is Jean Costello and I'm the Director of Evaluation at Homewood Research Institute. I'm pleased to be here today to present an update on some research we are doing that examines cannabis use trends and comorbidities in two addiction treatment populations. This work has been part of a collaborative effort between two research institutes, the Homewood Research Institute and the Peterborough Center for Addictions Research, as well as two treatment providers, the St. Joseph's Healthcare Hamilton and Homewood Health Center, and has been funded by the Canadian Centre on Substance Use and Addiction through the Closing the Gaps in Cannabis Research Funding Competition. I'd like to start by acknowledging the contributions of our research team, particularly Alicia Cooper for her role in analyzing the data and preparing the results that I'll be sharing with you today, as well as the contributions of our research partners, Dr. Elena Chorney, Chief of Addictions and Trauma Services at Homewood Health Center, and Dr. Jennifer Brash, Lead Psychiatrist in the Concurrent Disorders Program at St. Joseph's Healthcare Hamilton, for their contributions in reviewing and providing clinical insight into some of these findings. As you will recall, just over 2 years ago, cannabis became legal to possess, grow, purchase, sell, and distribute for recreational purposes in Canada. With the legalization of recreational cannabis, there became an urgent need to understand its effects on the health and well-being among all Canadians. Research to date has largely focused on youth and the general adult population. However, there still remains a need to study the effect of legalization on other at-risk populations, including people living with substance use disorders or concurrent disorders, many of whom commonly use cannabis. So with this research, we sought to address two objectives. First, to evaluate the potential impact of legalizing recreational cannabis among patients in two hospital-based addiction treatment populations. Second, to explore the associations between cannabis use, other substance use, and common psychiatric symptoms, including depression, anxiety, and PTSD. And we were particularly well positioned to address these objectives using the standardized clinical data collected upon admission by each of our research partners in the Addiction Medicine Program at Homewood Health Center, which provides an inpatient treatment up to 6 weeks in a semi-private setting, and in the Concurrent Disorders Program at St. Joseph's Healthcare Hamilton, which provides an outpatient treatment in a public setting. In both cases, the programs shared many of the same or similar measurement tools, allowing us to look for similarities and differences across these two treatment populations. Today, I'll be sharing with you some of the initial findings of this work. To address our first objective, we designed a study to evaluate the potential impact of legalizing recreational cannabis among patients in two hospital-based addiction treatment programs. The purpose of this first study was to examine the potential changes in cannabis use and other clinical indicators, including CUD symptom severity and readiness to quit. Second, we were interested in examining the potential changes in other substance use, including tobacco, alcohol, and other frequently used substances, as well as examining potential gender differences that may exist. Our notion was that if we were to see any increase in cannabis use among these two clinical populations, it may be cause for concern, not only from a programming and treatment perspective, but it may also signal trends that may not yet be detectable in the general population, or may only be seen among individuals with high levels of use. We used an interrupted time series design, which is useful when you have an outcome measured consistently prior to and following an intervention taking place, much like we had in this case of a natural experiment with the cannabis legalization. And we used a segmented regression to compare the pre-legalization trends of our outcomes to the post-legalization trends of those same outcomes. Here you see some of our sample characteristics. Notably, we had a much larger sample in the Homewood program, spanning a slightly longer study period, approximately 32 months, compared to the St. Joe's sample, which spanned a period of about 24 months. Critically, however, the data collection periods spanned both the pre- and post-legalization in both of these cases. In terms of the patient characteristics, the Homewood sample was composed of slightly more males who were slightly older compared to the St. Joe sample, and both samples reported high rates of cannabis use, with higher proportions in the St. Joe sample indicating that they had used cannabis or had screened positive for cannabis use disorder, whereas the Homewood sample seemed to have slightly higher proportions of those who had screened positive for another drug use disorder. Notably, there were nearly equal rates of those who had screened positive for alcohol use disorder, anxiety, depression, and PTSD. In these two graphs, you will see the results of our segmented regression analysis predicting the prevalence of cannabis use pre- and post-legalization. The first thing you'll notice is that over the study periods, the rates of cannabis use among the patients hovered between the 40 and 60% in the Homewood sample, and between 60 and 80% in the St. Joe's sample, slightly higher. The next thing you'll notice is the trend lines. The solid line before the policy period represents the pre-policy trend, while the extended dotted line reflects the predicted trend had the policy not occurred. The solid line following the policy date represents the actual trend over the post-policy period. What we are most interested in comparing are the two lines in the post-policy period. You can see in the Homewood sample the two lines are nearly identical, suggesting there was no change in the proportion of patients who use cannabis following legalization. And although there looks to be a difference between the two trend lines in the St. Joe sample, there was actually no statistical difference between the predicted and actual trends. In addition, we stratified the Homewood sample by males and females, since we had quite a large sample, and found similar results. That said, there were no changes in the proportions of males or females using cannabis following legalization. We also looked separately into those who had used cannabis to see if there was any change in CUD symptom severity as a result of the policy. Between the two samples, symptom severity was measured slightly differently, but here you can see that there was no difference in the trend line for the number of CUD symptoms among the Homewood sample, which was reported using the DSM-5 symptom severity checklist, and no difference in the trend lines for the QDIT scores among the St. Joe's sample. Again, there was also no change in CUD symptom severity for either males or females when we looked at these separately. And finally, we looked at patients' readiness to quit cannabis and whether this may have changed as a result of the policy. Here, in both cases, you can see a little bit of divergence in the slopes of the lines, with the post-policy trend tracking slightly lower than the predicted trend had the policy not occurred. However, this finding is not supported statistically, suggesting that the policy was not associated with a significant change in patients' readiness to quit using cannabis. However, when we stratified our analysis to look at males and females separately, we found a decreasing trend in readiness to quit among females, which approached significance at 0.05, but this was not the case for males. This highlights an area for possibly more research to further unpack potential differences, gender differences, when it comes to readiness or motivation to quit. In terms of our secondary outcomes, here you can see, again, no significant differences in the trend lines for tobacco use among the two samples, nor when we examined males and females separately. And no significant differences in the trend lines for alcohol use among the two samples. And again, no significant differences in the trend lines for other substance use among the two samples. Overall, these findings suggest that among this sample of patients, legalization of recreational cannabis was not associated with any significant change in any of the primary or secondary indicators we examined. So despite the potential concern that normalization may lead to increased use among this population, it appears that that has not yet been the case, as indicated in these two samples. However, there still remains a need to monitor cannabis use trends over the longer term to determine whether there may be lagged effects of the policy and to assess how other substance use behaviors may have varied over the same period. So to really fully understand any potential effect of the policy on this population. Furthermore, this research will want to consider how to evaluate subsequent phases of the policy, including the legalization of edibles, which came into effect October 2019. Now, switching gears slightly, as part of this work, we also wanted to examine associations between cannabis use, other substance use, and other common psychiatric symptoms, including depression, anxiety, and PTSD. Again, we used data collected from our two partner sites at Homewood and at St. Joe's, but as you will see here, we've restricted our Homewood sample slightly to limit the potential variability in the data due to some modifications in some of the measures that had been made. In any case, the similarities and differences among the two samples is pretty consistent to what I previously presented as part of study 1, so I won't spend much time on it here. In this study, we used variable-centered analyses to examine the interrelations among cannabis use, other substance use, and common psychiatric conditions like depression, anxiety, and PTSD, and latent profile analysis, a person-centered approach to identify possible subgroups of patients based on their cannabis use patterns, and then examined how these profiles may be associated with other substance use disorders or psychiatric conditions. From these two heat maps, you can see the correlation among our cannabis use variables that included frequency of use, severity of use, readiness and confidence to quit, with the degree of substance use disorder severity, and scores on the PCL-5, GAD-7, and PHQ-9, measuring PTSD, anxiety, and depression, respectively. Not surprising, we see a strong positive correlation between frequency and severity of cannabis use, and a strong negative correlation with readiness and confidence to quit across the two samples. We also see that for the most part, cannabis use frequency and severity was generally positively associated with other drug use, but negatively associated with alcohol use, while readiness and confidence to quit cannabis was negatively associated with other drug use and positively associated with alcohol use. Again, there was some consistency among the two samples here. Finally, we also see cannabis use frequency and severity as positively associated with symptoms related to PTSD, anxiety, and depression, while readiness and confidence to quit cannabis was negatively correlated with all three psychiatric conditions in the Homewood sample, and negatively correlated with PTSD in the St. Joe sample. With this insight, we then took a person-centered approach to see if we could identify subgroups of patients based on their cannabis use characteristics, and then looked to see how these profiles were related to other substance use disorders and psychiatric symptoms. These are some of our results from our latent profile analysis using our Homewood sample, where we found 5 unique subgroups of patients based on their cannabis use characteristics. The teal line in this graph essentially represents our control group, those who either did not use cannabis or did so very infrequently, who also reported no or low severity for cannabis use disorder and a very high readiness or confidence to quit, which characterized about 69% of our sample. Among the other 4 profiles, we see some variability in the frequency, severity, readiness, and confidence to quit. But the 2 that really stood out to us as being potentially high risk from a clinical perspective were those represented by the green and the pink line. The green line were those who reported a high frequency of severity and a very high readiness and confidence to quit upon entry into the program. And the pink line were those who reported equally high frequency, more moderate severity, but very low readiness and confidence to quit upon entry into the program. In both cases, we speculated that the degree and the nature of motivational intervention may need to look quite different among these subgroups of patients to ensure that treatment is successful. Generally, the other two profiles were somewhat more in the middle on these indicators. We also found very similar profiles among our St. Joe sample, giving us more confidence in these results. But for the sake of time, I will not be presenting these today. After identifying these 5 subgroups, we then used multinomial regression to determine which characteristics were associated with each of the profiles. For the sake of time, I'm only going to focus on the 2 subgroups that we identified as potentially high risk. In these cases, we found that compared to our control profile, those who reported high frequency and severity of cannabis use and high readiness and confidence to quit were more likely to be less educated and younger, more likely to screen positive for another drug use disorder, and more likely to screen positive for probable PTSD. While those who reported high frequency, moderate severity for cannabis use, and low readiness and confidence were more likely to be male, single, unemployed, less educated, and younger, and were also more likely to screen positive for another drug use disorder, as well as probable PTSD. Overall, in Study 1, we found legalization did not significantly change the patterns of cannabis use or other substance use among individuals in our 2 samples who were already engaged in treatment for substance use disorder or a concurrent disorder. In Study 2, we found that there were significant associations between cannabis use, other substance use, and psychiatric symptoms for PTSD, anxiety, and depression. And more specifically, the association between more frequent and severe cannabis use was quite significantly associated with a greater likelihood of drug use disorder or PTSD. And although we did not find much evidence of gender differences in the first study, we do plan to further explore potential gender differences in cannabis use profiles and potentially understand the unique characteristics associated with each profile. Finally, we will further consider the clinical implications of these findings, particularly in how they may inform more tailored treatment pathways for patients who use cannabis and are seeking treatment for substance use disorders or concurrent disorders. Again, thanks for joining today. If you have any questions about the presentation or the data that I presented today, please feel free to reach out to me at my email address provided on this slide. I'd be happy to address any of your questions. Thanks and bye for now.